So guys, the patient comes in. I'm here making the sauce for the chicken. Patient comes in complaining of, well, not the patient. Patient's parent comes in saying that their son has been complaining of groin pain for, call it 2 hours, sudden onset. Now this groin pain is worsening. It's not waxing and waning. Radiates to the lower abdomen. Patient vomited once. What's your first set of differential diagnosis? Patient, oh, I forgot to mention the age of the patient. The child is 16. So, with a child, something just bit me. Oh, so differential diagnosis. First things you're gonna say: testicular torsion, incarcerated inguinal hernia. Pretty much it's loin to groin, even though it might not move from the loin to groin, and it's lower abdominal pain that is in the groin, you'll have to say possibility of possibly renal calculi. Now I give this example because in the examination, what happens is that sometimes we forget our basics. So we're thinking complex things. 16-year-old boy with testicular groin pain, you have to rule out testicular torsion, and you have to rule out possibility of incarcerated bowel. You also have to rule out the possibility. What is this? Oh, this had an ant. Right, we have to rule out the possibility that the patient might also have renal calculi, although it's very unlikely at that age. Now, renal calculi usually presents with pain around the waist that radiates to the groin. Groin pain that's sudden onset for 2 hours, chances are, in a 16-year-old young male, I'm thinking testicular torsion. If it was an older gentleman, possibly it could be epididymal architis. It could still be epididymal architis in this patient too, but with an older patient, you're thinking maybe epididymal architis. And so for this patient, how would you investigate? For one, if you examine the patient's testicle and you realize that the spermatic cord is shortened, if the spermatic cord is shortened, what are you going to do? Now bear in mind that if the diagnosis is confirming that you might have a testicular torsion based on the history the patient has given, you have to take this patient to theater and do an exploratory exploration on the scrotum. However, you examine the patient's scrotum and it's not tender. The pain is actually in the groin itself or just in the inguinal region. You find a mass and the mass is not reducible. And I say not reducible, when you touch it, it's painful. The area you listen and you don't even hear any bowel sounds because you're thinking possibility that if it's there and it's bowel, you might hear a few bowel sounds in the swelling. But in this instance, you don't hear any bowel sounds. It's so thin that even just when you tap it or even rest your hand on it, the patient jumps out of the bed. Patient vomits a couple times. You're thinking strangulated hernia. Patient still has to go to theater. Epididymal architis, not so much. You might not have to take the patient to theater, but there has been an instance where I have seen a consultant wasn't able to get a definitive diagnosis from. He sent the patient for a scrotal ultrasound because it was a 48-year-old male who presented with scrotal swelling, and it was so tender and painful. The patient was behaving like if it was like he was just hopping out of the bed, vomiting. He just couldn't take the pain. So the diagnosis was not certain, so the patient was sent for a scrotal ultrasound which showed the blood flow was still in the testes. So they gave the patient analgesia, sent the patient to the ward just to monitor. Once again, the pain came back up again. Severe pain. We were there wondering like, what's going on with this patient, because I mean, his scrotum, there's still blood flow. There's no evidence that the spermatic cord was, torted in any way. So what's going on? In that instance, they had to do an exploration, and it was found that the patient there was epididymal architis, but the patient did have testes that could possibly be torting and untorting too. So they had to fix the testes into the sac. I think the procedure is called not jabule, it's jabule. And don't quote me, but I think it's jabule. But I know that they fix the testes into the sac. That's the main thing. The scrotal sac. And they subsequently discharged the patient was well. Now with renal calculi, patient comes in. Now renal calculi is very painful. I've never had it, but I've seen people have it, and when they have it, it's unbearable. Probably just as unbearable as a strangulated bowel. So renal calculi, what they had to do was patient comes in, first thing you do is you have to get this patient analgesia, settle this patient down. So if the patient is septic, which can happen in renal calculi, you might have to do your airway breathing circulation, your ATLS guidelines, stabilize the patient. Bolus this patient as well to airway breathing circulation. Sometimes in some instances, bolusing this patient does not help, and you may very well have to, if you're a junior doctor on the ward, you have to call for senior help. If not, you have to keep bolusing this patient, pass the catheter, and get this patient down for an urgent CT scan, a CT ultrasound, a CT KUB, or a KUB ultrasound. But we prefer a CT. Well, KUB ultrasound is very, you can do it more readily, because in most hospitals the CT machine is always jam packed. It's very hard to get a CT so late in the night, depending on the hour of the day. So abdominal ultrasound, KUB ultrasound, is better. Although you may not see as much detail as in a CT KUB, but you want to do that. So patients, you find a 0.6 centimeter stone in the kidneys, or in the bladder, not the bladder, sorry, in the ureters. In that instance, the examiner may ask you, so do you think this kidney stone is going to pass spontaneously? And you're going to say no. So the kidney stone is too big. I think if it's less than 0.4, or I think if we say less than 0.4, 0.5, but less than 0.4 from what I remember, you'll be on the money. Anything less than 0.4 will pass spontaneously. Anything greater than that, you're thinking that this stone is not going to pass. If it's less than that, you might give the patient tamsulosin, or something to help relax the ureters to help the stone pass. If the stone is bigger than that, you can't do that. So in some instances, let me just put this sauce on this. So in some instances, these patients can be managed with analgesia. What's the analgesia of choice for patients with renal calculi, or with low groin pain, or renal colic? Most persons give NSAIDs. I know there's some persons will argue and say, what happens if the patient has renal failure? Well, initially you're going to do the NSAIDs. If you find the patient has renal failure, you're going to give the patient another kind of analgesia, maybe Panadine or Panadol, or you might, if the patient is in such pain, which they will be, you might have to give them morphine. So for that instance, I'm still here by the way. So for that instance, you're thinking that this patient, if the patient settles, you could very well send the patient for a definitive CT, to delineate the genitourinary system, and then afterwards you can plan for subsequent management, whether it be stenting, nephrostomy, to remove basket removal of kidney stones. There's a whole host of things. I'm not an expert on urology, but these are basic things that they ask you in the MRCS examination, so you have to remember this. As for the strangulated hernia, laparotomy must be carried out. If they have viable bowel, they may reduce it back into the abdomen and monitor you. If they don't have viable bowel, they may have to resect and then reanastomose. That's a possibility. So and I also explained already for what they're going to do for the testicular torsion. For patients who come into you with a lot of my examination was scrotum and inguinal region, and the reason why they test on it is because you're expected to know that. A lot of the head and neck emergencies, they don't do that so much, but it can't hurt to know, because you may have a red herring. Like for me, my exam, lung cancer came, and I've not read lung cancer since medical school, and I don't remember much about it, because it's one of those things that unless you're actually working in a thoracic unit or pulmonology unit, you're not really going to use it that much. You can diagnose that a patient has a lung mass, but in terms of actually remembering, the management and how much to resect, those are not as high volume as a general surgery unit. So in a history station, with a patient that you suspect might have a ischemic body part, what do you think is a very important piece of information that you should not miss in a history? For one, duration. Now a patient who comes in and says they have had a testicular torsion and I'm not says they have testicular torsion, but says they're having pain in their scrotum. And this pain has been going on for 2 weeks. Now the possibilities, and the 16 years, or the possibility of it being testicular torsion is still there. But chances are it might not be. Because if it's testicular torsion, it means that the testes is torting and untorting, torting and untorting. That's a possibility. But it's unlikely to be. Now, if that patient comes in and they say they've had this testicular pain for, like I just said, 2 hours, 16-year-old male, severe testicular pain, testicular torsion must be ruled out. So that's that for that. Can't miss testicular torsion, that's a lawsuit waiting to happen. Examine, see if the scrotum is spermatic cord is shortened, and theatre. There's no conservative management that I know about, maybe it's changed, but you want to make sure this person doesn't lose their testes. Oh, another thing too, when they go in to fix testicular torsions, most times they fix both of the testes. Because one is mobile within the sac, and the other one most likely is going to be mobile too, so they fix both, despite the fact that you're having pain in the right side. You're trying to save this person's fertility. So if this person loses one, that's usually just half their fertility, kind of. Despite the fact that one testicle can still impregnate. So that's that. Just finished putting the sauce on my chicken. Hope this video helps with us preparing for the MRCs.